All right. Hi, everybody. Good afternoon. It's my pleasure to introduce Dr. James Harrop. Dr. Harrop is a professor, Department of Neurological Surgery at the Thomas Jefferson University in Philadelphia. Are you a Eagles fan?
I am an Eagles fan.
Okay, I hope that was a good.
Have to be.
It ought to be interesting game in a couple of weeks. He's also chief of division of spine and peripheral nerve surgery and neurosurgery director of the Delaware Valley Spinal Cord Center and director for adult reconstructive spine. He received his medical degree in Jefferson Medical School in '95 and completed an internship at Thomas Jefferson and then spine training at the Harrop. Also completed a combined neurosurgical and orthopedic spine at the Cleveland Clinic. He's been in practice since 2002 and as a director of the Division of Spine and Peripheral Nerve at Thomas Jefferson and Department of Neurological Surgery. He's a very, very busy clinical practice, and you'll see today he's also very active in research. He does approximately 350 cases annually. So I was just talking to him about how he balances all this clinical work with his research. He also covers, in area degenerative trauma, tumor infections, and for 20 years covers the level 1 trauma center, which is, again, I guess you're on call and all those other things. So very, very busy. Let's see, he's been active in research, over 550 peer-reviewed journal publications, numerous grants from the DoD, NIH as well. He's on governing boards of numerous spinal societies. He is president of the Cervical Spine Research Society, which I got an opportunity a couple of times to present there. Actually, in 2010, I presented for the first time some of the hypothermia work that we were doing. And when I got off the presentation, basically an orthopedic surgeon, Andy Cappuccino, comes up to me. And he was the orthopedic surgeon for the Buffalo Bills and said, "Dr. Dietrich, that was great. Next time I have an injured football player, I'm going to cool him." And then all that happened in the future. So, and again, James is one of our very important contributors to our multi-center trial in therapeutic hypothermia and spinal cord injury that is still ongoing. So we thank you for that. So we'll look forward to hearing your talk today. It's on spinal cord injury, past, present, and future. Are they connected? So Dr. Thank you very much for being here today and look forward to your talk. You'll be speaking tomorrow, I think at about 7 or 8 o'clock.
So if you get up early enough. Well, thank you. I can't believe my mom wrote that nice introduction. That was great. All right. So I changed my talk as you can see. I didn't try to set you up that way. I kind of sat back and I said, all right, who's going to be my audience? What do they want? Now, I believe in being entertaining. You might not learn anything, but I'm going to try to entertain you. Right, George? So I know George. George has been a good friend with the spinal cord injury hypothermia trial. He's not that nice. I just want everyone to know he's a really hard driver and his emails are horrible. So anyways, let's go through. My conflicts really shouldn't. I work with a little bit of companies, not really much for spinal cord injury and should not involve anything. So this is what I kind of did today. And what I want to do is I've changed my tactic, and this is going to be either a failure or a success. So you either get something out of this, an hour good sleep or some entertainment. And I want you to step back instead of going, be an active learner. I want you to be an active learner, because what I want you to do is think about, okay, no one's ever sat down and said, what are all the problems and what do I need to fix? And the front row is all the people probably my age and above. So this is for everyone behind them to sit back and go, okay, how am I going to fix this? Because I'm going to be not around in 50 years. And so I think really the important is I really want you guys and girls to think about these barriers and what are they. So the first thing I'm going to do is, people have told me that I'm a pessimist. So my psychologist has told me, new medications I'm on, I'm doing well. And they said to try to be more positive. So I'm going to try to start off a little positive, which in spinal cord world is hard to do. Number two is we're going to go through some problems, and this is going to go from nuts to bolts, everything you think about. I'm going to challenge you today. When you get done, when you're rounding or with your mentor or your teacher, I want you to go back to your basic thoughts you have and go, well, that might not be right. Dr. Harrop says that's BS. So all the fights you can get in, you can email me later and I'll get you out. I'll get you out to the suspension. And those are the neurosurgery residents over there. Is that right? In the green? Perfect. Just because you guys have a little thicker skin, so I can attack you with insensitive comments and you will answer them. If you want to interrupt me, no problem. And I'm probably behind. So anyways, I guess it doesn't go that way. Can I go backwards? Yeah, there we go. So really quickly, I'm not going to go through these, but we'll go through them. Last things I want to do is I've been in a lot of spinal cord trials. And what's the one consistency with spinal cord injury trials? Failures. So I'm going to try to give you some things I've learned, which you're not going to read in papers. And so if you're ever designing a study, and I'm going to say this out to the group, call the oldest person or the person most knowledgeable in that field and say, hey, can I do this? My junior partner just started practice, wanted to get a grant. He calls me up and he says, I'm doing a study on looking at financing, and starts talking like Latin to me. I have no idea what the hell he's talking about. It's 9 o'clock at night. I really don't care anymore. And I go, who is the world's best person? And he goes, oh, that'd be such and such. And I go, send him an email. And he goes, I can't email him. I go, he's going to answer you. Most people are in research to help people. Email him. He comes back a week later, happiest guy in the world. Again, I have no idea what the hell he's going to do, but the guy answered him, and now they have a collaboration with the world's greatest person. So reach out to people. And I think that's my take-home message. You're only allowed to get 3 take-home messages from a talk. So that's 1. So I'm almost done. So spinal cord injury. And we had a talk, and Dr. Lemon and I had to talk today, and it always amazed me because we're fighting a battle that evolution never wanted us to win. You ever think about that? What in evolution, neurologic injuries are bad. If you get a stroke, what happens? Your brain shuts down and it dies. And if you're an evolutionist, you'd go, well, a hemiplegic tribe member is probably not great, but for evolution, it might be beneficial for someone else. And so our bodies cut us off. So we are fighting against a battle that's very tough. And really, that is the take-home message for today. When I started my residency in 1995, conversion rates for spinal aid, and by the way, if I ask you a question, George, 99% of the times the answer is on the slide, okay? So don't freak out. So 99% when I graduated medical school, the conversion rates are A to A spinal cord injuries. Who knows what it was? Anyone? Bueller? George is on the slide. 5%. We'll say it's about what 5%. It was Ralph Marino wrote the classic paper in 1999. And that's horrible. Would anyone agree that's horrible? What do you think the conversion rate now is? 25. Very good, George. George cheated and looked at my slides. So it's about 16%. And then again, Ralph Marino, who worked at Jefferson, great colleague and collaborator, really bright guy. He went back and he just published this paper looking at the Alabama, the Asia groups. And what did he show? He said, we have done great. So we now have a conversion rate of 16%. And the target group, if you looked at it, are the cervicals we're doing. Cervical conversion rate is what? It's almost 30%. So congratulations. So why is it better? Anyone? Neurosurgery residents? Why is it better? Better surgery. I think that's probably an answer. We'll talk about that. And we probably take care of their blood pressure better. Those to me are probably the 2 simplest things because we're not using any meds. All right. So, and I talked about tetraplegic patients. Sorry. The third part of the thing is, guess what? It's not only us. The number of injuries when the city pools opened up in Philadelphia that weekend, every year when I was a resident, you didn't want to be on call because the kids climbed over the fence and they dove into the pool. And we would get at least 1 or 2 high cervical quads from breaking their neck in the pool. It doesn't happen now. As much as people say millennials are idiots, you guys are a lot brighter than us. You learn, you listen, you don't drunk drive, you wear seatbelts. So congratulations. I don't know if anyone's in a millennial. I don't even know what a millennial is, but congratulations. Next problem. Now we're going to get into the problems. This is where it gets the black cloud of me comes over, and I'm going to go through some of these things really quickly. If I run out of time, let me know, because the problem is having a neurosurgeon talk is they don't shut up. This is a classic paper by Anthony Burns. Nice guys up in Toronto now, was at Jefferson when he trained. And what he looked at and said, the hardest thing about examining a spinal cord injury patient is what? They're all different. if you're going to be a neurosurgeon, your life is going to stink because your exam is different. And you have to start understanding that you're trying to hit a curve. And so a Hoffman sign on an 18-year-old woman is normal. A Hoffman sign on a 90-year-old person isn't. And so the neurologic exam alternates all the time. So he basically showed that if you're doing prognostic, don't tell a spinal cord injured patient within the first 2 weeks of their anything what their prognosis is. I've seen more spinal cord injured patients than probably most people in the world. I have never told one their prognosis within the first week. Why? Because in clinic, I've seen hundreds of patients who are rip shit mad at their doctors because they're walking or not walking because their doctor told them something. So that's lesson 2. Don't tell prognosis spinal cord injury. I'll tell them you have a bad injury, you have a good injury, but give them at least 2 weeks in order to help to quantify that out. We'll skip through that. That basically said our accuracy in the diagnosis in the ER is horrible. And the second thing is this is another thing. Who here does studies? Who's filled out an INSCI exam? Anyone? George? Anyone else besides George? The neurosurgery residents have. What do you think the completion rate is? This is the European INSCI database. It's only 39% of the people that we're trying to get data on people. So this is my plea to you guys. If you have to put something in, it is painful to fill out these forms. And I'll tell you, only 39% of them got filled out, and only 69% of them they filled out right. So 39 to 40%, you're talking about 18% of the things actually got done right. So if you're going to be in a study, make sure you put the time and effort into it. I wanted to give a little, does anyone know John Dituno? Anyone ever? John Dituno? John Dituno was probably one of the premier spinal cord injuries rehab doctors. Is there any rehab doctor people out there? Physiatrist, PT? No one? Are you guys all homeless people? Like just got like a free air conditioning? So anyways, the Dituno was unbelievable. And if you want to give accolades to people, the rehab people are way ahead of patient reported outcomes before anyone. The Asia exam was 30 years ahead of anyone, but it's still not the greatest thing in the world. And the 2 things I just want to point out here, this is Dituno's. Does anyone know what a delayed planner response is? Anyone? So delayed planner response, you know what Babinski is? So Babinski, a delayed Babinski is called a delayed planner response. It's the worst. If you ever see someone in the emergency room and they have delayed planner, that means you stroke the bottom of their foot and about 2 seconds later, they get a Babinski. That is almost a catastrophic sign that they're not going to get better from a spinal cord injury. But by the way, don't tell them that. That's the other thing. So he came through and showed this, that the exams didn't really pull out. Now we're going to step back and talk about this paper. Does anyone notice anything about it? George? George, it's freaking Miami's colors. I stole it from Dr. Levy. You were actually there when he gave this talk. Anyways, I stole it from Dr. Levy because him and I have actually, and I'll get into this when we talk about the central cord injured patients really quickly, but our thinking of Netter's anatomy, and who's our anatomy people? Anatomists, is probably not correct or incorrect. And I'm not going to go there because these 2 guys are way brighter than I am. But the way we think about things, we do it and then we evolve to it and we stick with it. And I'm going to argue later that we're probably not right. And we'll see if we're there. And this is based on Dr. Bunge's work. So if anyone wants to attack me, you're attacking the building you're in. So now we're going to step back. Where's my, you're the only resident, the rest of the guys, emergency calls, operating room. Yeah, I had to answer his girlfriend. I've been there before. That's all right. We have become a society that is visually in tune to everything. So people now will look at an MRI and decide what needs to be done with someone. This is my 3rd point, and then I'll shut up after this. Step away as young educators, and you are treating patients and not MRIs. My orthopedic colleagues, who I love, everything is on their MRI. They decide who they're going to operate on, what they're going to operate on, and why they're going to operate on by looking at the MRI, particularly in cervical surgery. Don't do that. You are operating on people, and we don't know what the prognosis is. People will say T2 signal in the spinal cord needs to be operated on. You are a great bullshitter, by the way. But the the deal is this: is there's no data in the world that says T2 signals in the cord alone. And I wish Dr. Levy was here because I'd argue with him because he's like, oh, I operate all the time on T2 signal in the cord. I'm like, he's like, well, Phil, there's something pathophysiologically different happening to that cord. And I'm like, yeah, but you don't know if it's good or bad, but we'll get into that. So here's the only time you have to wake up. Ready? 3 spinal cords. I took axial images. Who wants to be A, B, and C? Look at them for a second. I'll let you guys choose. Where's my neurosurgery resident? The BSer. What do you want to be? A, B, or C? A? Anyone else? Who wants to be A? Put your hands up. Who wants to be B? Who wants to be B? It looks like Mickey Mouse. It's kind of cute. Who wants to be C? Now you got to realize I did this for a reason, right? I want to be C. And the reason why is C is neurologically 100% normal. The guy has no problems whatsoever. He's actually my patient. I've been following him since the first day I started practice almost. I've been following him 22 years. He has his syrinx. He is asymptomatic. And so every year he comes in, it's my favorite office visit because I know it's going to be 4 seconds long. I go in, I see him, he's neurologically normal and he leaves. And he's great. B, what's B? B is an ependymoma. I just told George the answer is on top of the slide. It's a spinal cord tumor. It's a benign spinal cord tumor. The guy was born with it. It grew and grew. He had mild spasticity in his hand. We took the tumor out. That's what his spinal cord looked like afterwards. Every year he comes in for clinic for a checkup and I vomit because I look at his MRI and then I walk in the room and you can't even tell. C is a 30-year-old ASIA spinal cord injured patient. Who wanted it? He wanted to be him. Now, why is that impressive to me? One is, if you're a spinal cord injury guy, there's only about a 2 to 3 centimeter gap where he doesn't have normal spinal cord injury. And the other thing that's amazing is thoracic cord almost looks completely normal, but he's functionally can't do anything. So be very careful with your radiology, what you look at, what you go. Next problem is what? As we look at spinal cord injured patients. Do you guys have this problem in Miami? You might not have it. In Philadelphia, we don't see young people in spinal cord injuries anymore. I mean, it's amazing. I mean, every spinal cord injury I see is probably 60 to 80 years old. I didn't know people lived this long before I went into medicine, but it's amazing. So this is a paper we wrote years back, but it basically showed 300% increase in the age of the spinal cord injured population. Now, why do I bring that up? Because this is your practice as you guys get older. Why? 1960, in 100 years, we used to have people die as they get older. Look at it now. This is a U.S. government expectation. 85-year-old population isn't going to die off. What's the mean life expectancy in the U.S.? And it's probably higher in Miami, I would guess. 78. But here's a better question. What's the mean survival if you live to be 78? Who said that? That's fantastic. Are you turning 78? No. No. I'm kidding. 48. No, but that's right. It's 15 years, which is, I see patients all the time in clinic and I tell them that and they're like, they figure that they make 78. If they make 79, they're great. But in reality, they have a 50% shot at making 93. So well, that was great. All right. Next problem is what? We like to be simple. 17,000 spinal cord injuries a year. So what do? We put them all in one bag, right? So there's 17,000 spinal cord injury. The problem, this kid came into my hospital, C4 ASIA. This is why you don't mess with Philadelphia people. Him and his brother got in a fight. His brother went to bed. The younger brother went in the kitchen, grabbed a knife and stabbed him in the back of the neck. And unfortunately, he cut his spinal cord in half, which almost never see. I mean, I've probably seen 10 transections in my life. Most of them are thoracic cord injuries. So you really don't see transections very often. And we put them in the same backs as this guy, who is a central cord injury. Now, I want you to remember this right here. This is Netter's picture. Remember Netter? You guys still use Netter in med school? And then the guy next to it is Schneider's original diagram of what is central cord injury, right? You injure the central part of the spinal cord. So it's sort of like the old man in the barrel. Who believes that? Anyone? Anyone believe in central cords? Now, I'm going to argue something else about central cord injuries. It's the only clinical diagnosis that we contribute to spinal cord injuries. You have all these classifications and everything, and then you make a separate population called central cord injuries, which are clinical diagnosis, has nothing to do with how, it is how they get injured, but it's very interesting, completely subset of group. So I argue that we probably need to get rid of that. So what happens? You need to clinically hyperextend your neck, usually an older patient, spondylitic injury, and their hands have to be weaker than their legs. You can't have bowel and bladder things. The problem is this is Dr. Bunge's work. And what did he do with Alan Levy? Alan and him had you guys probably still do. Do you guys still have your collection of spinal cord injuries? So you guys used to have the largest collection. We used to send them down all the time. And he went through, I think it was 9 patients they went through, and they did histology of the central cord injured patients, and then they markered where the injuries are. The problem is your central cord injury doesn't have a central cord injury. And so it goes all the way back to this first paper we talked about, where I totally agree with Alan. And he came up to Jefferson and gave this talk about, you guys know what Bell's paralysis is? You ever heard of that? Bell's paralysis, a guy outside of Cleveland came up with it, and it was from a C2 fracture. And the guy had upper deltoid weakness. And he thought it was because he injured the decussations of the pyramids as they came down at the brainstem. Probably it isn't. It's probably evolutionary wise, our corticospinal tracts are more sensitive than the rest of the areas. And so when you get a milder spinal cord injury, you knock out your hands more than your legs.
Is that because of position in the vertebral column?
I don't think so, but it's very interesting you ask that, because if you injure the cord where, you'll see people over the years and you really look at it, most injuries happen where? At right around 5-6. And so they knock out their hands. So my experience has been, if you look at where their injury is, it's usually about 2 levels down is what gets affected, right? Because the motor neurons have to go up. So if you hit up at the dens, they usually lose their C4 or 5 areas. The second thing that's kind of interesting over the years is if you have ventral cord compression, C3-4 people tend to be much more symptomatic than C6-7 people. And I think that's because your motor neuron tracts are more anterior up at C3-4 than down further. But that's a complete guess. Now we're going to completely go off record and say, how about this? Thoracic myelopathy. How are they going to present? Who's going to get the answer? You guys know what thoracic, pressure on your thoracic spinal cord. You're going to see these people the rest of your life, and I'm going to give you a hint how to deal with it. No, but close. Legs is right. It's proximal legs. So what these people do is they can't walk, and they can't go up their stairs, and they can't get up out of a chair standing. And it's because you knock out, those are the weakest fibers, your iliopsoas, your hip flexor muscles. And so they knock those out first. And so the reason I'm telling you about this, you'll get called on a consult from oncology, and they will say, patient got admitted for X, and they will be weak in their legs, and they'll have a thoracic tumor, but everyone's going to write that their exam is normal. Because when you test their strength in the bed, you don't test their leg, your hip flexors, because you bend your knees up and you push down and they put their heels into the bed. So just a little pearl. So in the office, thoracic myelopathy gets them to stand up out of a chair. If they can stand out of a chair, they have normal hip flexors. So varsity question, what is the second muscle to lose? What's the second muscle group that gets weak in thoracic myelopathy? It's going to be your anterior tibialis, because your anterior tibs are much weaker muscle. Your gastrocs get weak. No one ever presents you and say, hey, I have weak gastrocs. No one ever tells you they have weak quads. I mean, I'll tell you my life. I think I've seen it once or twice in my life, because your muscles are so, that's 215 pounds you're lifting up. Your anterior tib lifts up like 5 pounds because it's a weak muscle. And so that muscle, you lose those fibers. You present much quicker if you have a thoracic injury because you lose your foot. Does that make sense? You would think it is. Humans are the most amazing things. If you don't have pain, you will not present to your doctor. To be balanced, I had a lady once who came in my house and I'm like, what the hell are you doing? And she's the most floridly myelopathic lady in the world. And she goes, oh, I bought a new house. I go, okay. And she goes, I put railings around the whole house because she didn't have pain. She just accommodated her house so she could scoot. And she came in like a wheelchair. So people don't come in for balanced weakness. They come in pain. Oh my God, they'll call you, they'll torture you for all night long. But the myelopathy people don't. Last thing I just want to bring up real quickly, falls. You know, we used to see car accidents, trauma. And so this is what makes the world so hard to compare populations, because in 20 years, I just showed you, we've gone from young people in car accidents to old people slipping on leaves. And that's, if you're comparing spinal cord injured populations, you can't do it over a large database. So that's one of our things. All right, we're going to switch gears a tiny bit, and then we're going to talk about time to intervene. You guys getting bored? You want to hear anything different or? Okay, so we as neurosurgeons and neurologists know time to spine. Last decade, brain, everywhere in the world, you saw a poster, you know, your mom's usually screaming at you about taking aspirin and Tylenol and making sure that you get someone to the emergency room fast with the TIA. We forgot about the spinal cord. And it's a very interesting thing. I'll tell you a story if I don't have that, if we have time. This guy came in and saw me. He's a vet. And by the way, I don't know if you know this, when you sign up for the Army, you get a bonus. And so I've taken care of a bunch of, this guy wasn't a vet, he just signed up. They go out and buy a motorcycle. So he went out and got a motorcycle and he got a spinal cord injury. They found him on the side of a road. Can't get an exam because he's got a head injury, concussed or whatever. But he comes into my place at 5 o'clock in the morning. What are you going to do? When? What are you going to go to church for 3 hours? But so, and just to bring it out to the point of, we've evolved to that. In my day, we used to do 72 hours, you know, whatever, do whatever, bring them in, get it. There wasn't any emergency. And we'll talk about that really quickly. The second question I want you to think about is, if the patient's in Asia A, means no motor or no, you guys all know what Asia A's mean? I'm like assuming everyone does. Asia A means no motor or no sensation below. That's the worst spinal cord injury. B means you have sensation. C means you have useful, you have some motor, not useful. And D means you have functional motor. Now, here's a little caveat that most people don't know. What does Asia E mean? No. Asia E actually means that you had a spinal cord injury and now you are normal. Intact means you're intact. And so it's, well, that means you had to have an injury. George is going to argue with me. George, you should be like a politician, a lawyer. All right, fine, George, you're right. The deal is, this goes back to this, is you very, 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 very rarely in your life will ever see an AGE. I mean, it's almost like central cord injuries. I can always find something with them. They always have some deficit. So it's very unusual to get rare. This is a European group. They went out there and they said, all right, people, Asia A comes in, B's, C's, or D's. What are you going to do? And what do you think they said? Asia A's earlier or later? The guy's done, right? He's got an Asia A. You might as well go have your bagel and coffee and come back later. Asia incompletes. Oh my God, that guy's got an incomplete neurologic injury. I got to help that guy or girl. Now, I tend to be sexist because 80% of spinal cord injuries are men. Here's the deal. And you heard it here first. Who cares about the Asia B's, C's, and D's? They're going to get better on their own. If you look at the natural history and evolution, they get better. So if you got to delay someone, those guys are the ones you should be delay. Asia A's, if you're going to operate on someone early, that's the person hits the door, get them up to the operating room as fast as you can. And this is still not totally understood in neurosurgery. And you're going to see, this is the paper we wrote about it. Oh, this is a different paper. This is a database that Mike Failing and I and a bunch of people we put it in Neurology Lancet. We looked at 4 different databases and looked at timing of spinal cord injury and is there timing to do it? Long story short, what we're trying to see is there a window that effect seems to fall off? And so it used to be 24 hours because that was convenient time. It actually started out like this. When I was a resident, it was a week. If you operated on him within a week, that was good. And then it became 3 days. And then it became 48 hours. And then it became 24 hours. And so you notice there was always a pattern of times that people just did it. And they were arbitrary times. So we said, what's early and late? Surgery. When is early? Well, that's I guess you're answering my question for me. It is defined by that paper. So when I was a resident 25 years ago, early was if I operated on them within a week. Late was if I did them after a week. And then over my career, I've watched it get down, down, down. So presently in the world today, most people would probably say 24 hours. Doing it before 24 hours is early, after 24 hours is late. So when you look at this, what they showed is that the effect of early surgery tends to lose it after 36 hours. So if you're going to operate on someone early, you probably should do it before 36 hours. That's sort of the take home message of that. Staskis, very interesting paper. If you want to read about it, like most papers, it had a flaw in it. And I'm going to tell you something that we got to turn off we can leave the recording on, but so we decided to do a randomized trial for Staskis, and it was in a bunch of big centers. And at Jefferson, we were the only people that could enroll patients because we'd get them to the operating soon. So we did a cohort study analysis. So it's very easy. So I somehow was the unluckiest guy in the world. Like, I should never go to Vegas. I enrolled every one of the early surgeries at 2:00 in the morning. And I'm like, why do I get so unlucky? And I'm a believer, listen, if you do a randomized study, you're in or out. And so I talk to the patients and do everything. So I'll tell Alan's going to love this story. So we're sitting there 10 years later after this Staskis study. And I go, how come I was so unlucky? Why did I get picked to do the randomized late at night? George, you're going to love this too. Did I tell you this story? And so I meet one of the orthopedic guys. Now he's 10 years out. He's not threatened by the guys at Jefferson anymore. And he goes, "Oh, you didn't know?" And I look at I didn't know what. And he goes, "Oh, in orthopedics, if we ever randomize a patient to early in the middle of the night, we just pulled a new number until we kept on pulling them until we got the late one. And then that's the patient we enrolled." And I go, "Really?" And I didn't have that luck. Every time they must have pulled early for me every single time. So be very careful. But so anyways, we didn't randomize the patients, and long story short, it turned out tended to be, as you went back and you asked the question, sir, earlier, it tended to be early versus early somewhat because it was 48 hours versus 14 hours. And with it said, and this is sort of the take home message. So this is my fourth message for you guys. If that study showed that who did well, you did well, and it was statistically significant to improve 2 levels. Okay. So the people that improved 2 levels did better with early surgery, or 3 levels. Now, here's the caveat. If you're an Asia D, you're not going to be an Asia F because Asia Fs don't exist. So if you're a C, you're probably not going to make it to be an E because, as I told you before, E's are very rare. So the people that benefit the best from the early surgery were the A's and the B's. Now, how common are B's? B's are pretty freaking rare to come in from the scene to see a B. So my argument, just to go full circle, is that if you're an Asia A, I take you to the operating room right away. And we can go through protocols and different things later, but we at our place, you hit the ER door, you get the CAT scan, you go to MRI, you get axial, sagittal T2s, and then you go right to the OR. And so we try to get them in ASAP. And that's sort of evolved. Sometimes the residents kind of miss the message. The other day I was on call and they're like, "We have a central cord injury. We're going to put a central line in them and get them in the OR in 2 hours." And I'm like, why don't we send them home in a collar? Because to me, central cord injuries are different animals. All right. Now, just to press home that message before, I'll skip through this a little bit. This is a great meta-analysis. And what they did is, remember I said 24 hours is good, but I'm a believer early might be even better. So this meta-analysis, what they did is they looked at, what if we take all those databases and we pull out and we use 8-hour window? Now you could say, well, Dr. Harrop, there's selection bias because if they're 8 hours, they're probably not as sick as the other patients. Totally agree with you. But it's what we got. And if you look at this, definite advantage to operate less than 8 hours in terms of neurologic recovery. Now, the interesting part about this, to go back to my original and full circle, my message I said before, when they broke them down to complete spinal cord injuries and incompletes, what happened? The completes, you get even better chances of recovery. Your odds ratio go up. The incompletes doesn't really change. So again, argues that if you're going to go early, and I don't have a problem going early with the incompletes, but my message is definitely get the completes to the OR early. All right, now we're on number 6. Alan, number 5, 1 through 5 were freaking fantastic. I'm on we're kind of losing a little. You come down. Number 6 is this is the Pennsylvania trial. Pennsylvania is an interesting place. And I got to start picking up my pace. But long story short is we select spinal cord injury as the lowest priority to transport to a tertiary hospital of all your neurologic injured patients. So my message to you and your message to your ER doctors is get the spinal cord injured patients to a place, because a lot of the drug trials and studies are now looking at 8 hours for their windows. And so our place is get them to us as fast as you can. Now, just to be fully honest, NACTIN, and I guess Jim just ran out, but NACTIN is North American Clinical Trials. Jim and I are the PIs for it. Very interestingly, we recently published some of our papers, but what was very interesting is we are probably the most aggressive surgeons out there, at least I think we are, in a lot of that group. Only 50% of the patients that we enrolled through NACTIN got early surgery. So it's not like I'm telling everyone to improve. I think we all have to improve. And don't get me wrong, I'm a believer in guidelines. Guidelines means that everything is not black or white. There's a lot of gray. There's absolutely patients that you cannot get into the operating room within 24 hours. That doesn't mean that's wrong. And classic example, closed head injury, concurrent spinal cord injury, take care of the head. We can skip through that. That's not that exciting. And this just sort of goes out and gives you, we as Americans tend to be American centric. As our system evolves, we have to help out the world evolve a lot more. And if you go into other countries in different worlds, their priorities and their resources are a lot less than ours. All right. Now we're going to get sort of some of the newer different things. Spinal cord injury perfusion. Perfusion, a good thing or a bad thing? Oh, wow, man. I scared all your residents off. I asked them a couple of questions and they all ran. The guidelines say we should use spinal cord injuries. And anyone know Brian Kwan? Probably no one knows Brian Kwan. You know Brian Kwan? You guys know Brian? Brian's a great guy. Superstar. You know whose fellow he was? Mine, like, shocker. I took out at least 10 of his IQ points. The guy would be a genius if he didn't rotate with me. Yeah. He's an orthopedic surgeon who is just a tremendous guy. Nicest guy. Goes back to our Canadian talk. I mean, another Canadian that they don't make them bad up there. So what he started talking about was he was really into perfusion pressures. And you got to remember, he's an orthopedic surgeon. And so he, this to us should have been no brainers being neurosurgeons. And he came up with the idea of, well, maybe we need to maximize spinal cord injury perfusion. Now, I'm going to tell you, and this is embarrassing to say, but I'll tell you, when I was a resident fellow, and Alan and some of the other people can tell you this, 2 things happened that I'm horrified about. One is I remember going and operating with certain surgeons that would say, drop the systolic pressures to 50. And you would be like, because they believed that it would bleed less when you operate on a spine. That's one horrifying thing. And number 2 was we used to go around in the ICU and look at the spinal cord injured patients, which again were typically young males, and their blood pressures would be in the means in the 40. And the nurse would go, he doesn't have a blood pressure. And you'd go, oh yeah, but he's making urine. So that's all right. We can leave him at that blood pressure. So I'm happy to say I'm not as dumb as I used to be. But with that said is, if you look at this Starling curve, remember this, guys, all the way back from medical school, first year, second year medical school. You probably were a little hungover that day, but that's just try to go back. So if you look at this, this is the top slide. Remember what happens is autoregulation. Your body autoregulates, right? And that's what you do. The problem is in the bottom is 2 rat examples. Is the control sort of look like a Starling curve on the left. On the right is a mild and a severe spinal cord injury. When you have a severe spinal cord injury, your spinal cord doesn't autoregulate. Make sense? And so this, oh, did I miss it? Sorry, I just blew my slide. So what happens is when you get your spinal cord injury, you're down at the bottom here. And this is sort of Nick Theodore. Actually, I don't know. Did you see Nick's new thing? He just came out with an ultrasound. It's very interesting. I actually have the slides, but I couldn't get them out of my Dropbox. If you have a spinal cord injury, this is the blue line. So we tend to do what? We raise the blood pressure. which is great, right? And what is raising the blood pressure in? That makes you get to the red line. When you're, and he did this study looking at ultrasound perfusion of the spinal cord. I think he did it on pigs. And then he put a lumbar drain in. And the lumbar drain is the CSF, it's the purple line. And so what he showed is, yeah, you get a little bit better with the lumbar drain, but maybe not great. Which, remember, what does the lumbar drain do? It helps with venous outflow, right? So venous outflow and jacking the blood pressure up. If you synergistically put a lumbar drain in and jack their blood pressure up, you get a synergistic effect, which is the top line. And there's some belief, and I've started doing this in my practice, where I put lumbar drains in people and try to increase their blood pressure, because I do think it helps perfuse the spinal cord. He did a study called the Camper study, looked at 91 patients. Take home message is this: if he kept their perfusion above 50, they had a much better conversion rate from being an Asia A. Now, again, you can go back and you go, Dr. Harrop, you're an idiot, because if they have a thoracic spinal cord injury and they're complete, they lose their autonomics, and that makes it much harder to perfuse their spinal cord. Totally agree with that, but it is something to shoot for, and it's something to look for down the road. So I give Brian a lot of credit, and I do think perfusion is exceptionally important, and I do think it's something that's changed for us as we've gone on. Anyone know Bizan? Yes, sir.
I had a question. So if you increase the blood pressure and don't change the venous outflow, would that increase pressure within the parenchyma?
So I think what it does is if you increase that's the red line. You got a spinal cord injury, you can only go so high because then the spinal cord expands and you can only give so much force through. So if you think of it like a funnel, so the funnel, you can only put so much pressure on the funnel because it's going to come out the bottom of the funnel.
So if you increase the outflow,
that's what a lumbar drain does. I think it makes the funnel hole bigger.
It also should probably reduce the pressure within the parenchymal tissue, correct?
Correct.
And allow for oxygenation.
We're going to get to that in 1 second too. So the spinal cord, in case people don't know, is like a hot dog. It's got a casing around it. And so his point is right on. When you put a lot of blood pressure in it, it expands it, right? And so your question is, well, is forcing that much blood in good or bad? Because are you increasing the intramedullary pressure? So I totally agree with that. All right, let me just go through. Bijan, everyone know Bijan? Bijan's a shock trauma, hilarious. Bijan gets an MRI on his patients like every 60 seconds. He's hilarious. So he knows more about radiology and imaging, and this is sobering, another sobering. Whenever you think you're good, don't listen to one of my talks, because I tend to be a realist and I go back and look at the data. We do horrible at decompressing the spinal cord injury, and this is cervical spinal cord. So he gets MRIs on all his patients postoperatively and showed that even in the great cases, 49%, only 50% of the ACFs got decompressed, and only about 80% of the posterior cervical laminectomies. Now, this is where I argue with Bijan a little bit, just to go back to this. The problem is in the spinal cord injury population, they swell their spinal cord up, right? And so you open the canal, and the only way to make them more decompressed is open the dura or open the pia. And we can talk about that in 1 second. But it's just out there for you to think. All right, I have 4 minutes, and I'm going to go through this really quick. Riluzole, we'll get over with. ALS drug, just tried out. Well, we had multiple different theories with this. What I learned with this is very interesting in your dosing effects, how it gets in. Patients' doses are all over the boards, depending. We all think we give them the same medications, and we don't. We kind of messed up on different things with that. That'll get off inside that. I'm going to skip through really stem cells really quickly. And I just wanted to bring up stem cells because since COVID happened, there was a huge flux with stem cells before COVID. And most of the clinical trials I've seen have regressed, and I'm not totally sure why. This is the Asterias study, which was very positive and I'm a skeptic, and you can talk to Alan. I don't believe anything. That's the results. The results are very good with their injections and their trials. And it's sort of, we sort of lost it. The one thing I do want to remind everyone, and I was just on a call the other day, the reason you have a clinical trial is because everything in life isn't good. You can have bad things. And what happens when you get a bad stem cell? Well, this is olfactory sheathing cells they put in a kid in Russia. Kid came back in the States. They thought spinal cord injury on the left. On the right, he came back. They thought he had a teratoma or a tumor in him. They did surgery, and it came back as respiratory epithelia in his back with a mucosa in his spinal cord. So you got to remember, and Jim Guest isn't here, but he's really on the ball on purity of your cells when you put in. And so if you look at it, this is his paper with your guys and your great work with Schwann cells. It's really important to know the purity of your product going in. And that's why I'm like, if you're going to do stem cells or other those things, make sure you do it through a clinical trial. I do want to talk about this for 1 second, because I think this is the most fascinating study. And I'm involved in this study. I'm the largest enroller in this study, and I'm the most skeptical human being about them. And I have no financial incentive at all. So this is called In Vivo. And it's a very interesting study because what they decided to do was spinal cord injury, broken. And what we found out in a couple other studies, in the Geron study, is when we did ultrasounds on the spinal cords, they have a cyst in the center. You go back to the MRI, you can't see it on the MRI because it's all proteinaceous. But when you get MRI, you get an ultrasound right after surgery, right after the injury, they actually have a necrotic center. And so these guys came up with open the PIA and you put a scaffolding in there. And I'm like, that's stupid. That's not going to work. Their results have been excellent, to say the least. This is why I think it works. Let me see if I can get this going. This is one of the surgeons. This is not me because I shake a lot more. So what they did is spinal cord, they opened up the PIA, the dura is open, and now all they're doing is getting through the PIA. And what happens? It's expressing all the highly toxic, acidic, proteinaceous material that I think got all your inhibitors in it are now being released. So what do? They took the pressure off the spinal cord, sort of like a hemicraniectomy. So took off all the pressures, the stuff they can. This, I think, I'm not really totally sure this does anything, but I'm not going to go there. They put a little tube in there, and I'll tell you why I don't believe it does anything. The conversion rates are very early on these people. So if you look at it, it's about 3 months. And I go, there's no way a neuron's growing through that thing at 3 months. The other thing is, if you ever think you're bright, Alan Levy, just go back in the literature, because there's always a guy smarter than you or a girl. This is Dr. Allen. Dr. Allen in 1918 did the exact same experiment on beagles. And his recovery rates, 5 dogs. He did a whack the dog, open up the PIA, second best institution in Philadelphia, I might add. And the dogs actually had a great recovery. It's so funny reading these old papers from like 100 years ago, because it's all prose. You know, there's no data. It's like the dogs did great. And you're like, okay, what the hell does that mean? All right. Want to really quickly out, and this is again, you guys are great. I talked about your Schwann cells, fantastic leading the world. Alan came to me with the hypothermia stuff, and I'm like, oh, I didn't, again, I said, I don't totally believe it. You guys in Miami, I saw your data, Alan and Michael Wang and Alan Levy on a paper. I'm like, yeah, that's factual. And so he asked me to be involved in a study. And I have always been, if it's going to do no harm to my patients and we can learn something, I'm happy to do it, because you always learn something when you do a study. And I will give you accolades, unbelievably well-run study. George has been with his team. I don't know when you're going to get your data out, but this is a safety paper we wrote where it is extremely well tolerated by the patients. And so I do think there is definitely something to hypothermia. I think it's going to be it's going to be something that we're going to use for patients. It's going to be one of the keys in the puzzle, but not all of it. Last thing, and now I'm going to move on. This is going to get really quick because I'm almost over. Neuromodulation. Does anyone want to be a neurosurgeon or training to be a neurosurgeon? Who wants to do practices, but not perfectly? This is Susie Harker's work, and this to me is probably all the residents coming to interview, they're like, I'm going to go into neuromodulation. The world has changed, because when I was a resident, that meant you were going to put spinal cord stimulators and workman comp people. And now it's so exciting. I mean, what they've done in the spinal cord injury, the Parkinsonian population is just amazing. This is to follow up with Susie's work. She gave me these slides just to talk about. It doesn't just affect ambulation. So that was her first patient that went on to have spontaneous motion in that slide. And the reason I showed is the amount of physical therapy that they do on these people is immense. And so it's not, hey, just throw a spinal cord stimulator on them, they're done. Because the thought process is they think the electrical stimulation works on the DRG, and that causes nerve ingrowth. It's pretty interesting. What amazes me is everything you learned. If you're just sit back and listen to the signal and the noise, so to speak, they have now shown that these people get better autonomic regulation. And so spinal cord injury people die a lot of time because they die of cardiac myopathy death. And so if you can get these people to turn on their stimulator, and if you see the top show, it shows the difference between having stimulator and non-stimulator in terms of their heart rate, blood pressure, and systolic. That's great. The second thing that was unbelievable, and I don't have this on the slide, bladder changes and neuropathic pain is unbelievable. So I think this is fascinating, and I'm so glad that she started it and been onto it. Now, really quickly, I got two quick things. This is the coolest thing. This was done at Ohio State. This is somewhat older. And what they did is, this is a C4, C5 paraplegic kid, 25 years old. They put a Utah array onto his motor strip, did a functional MRI to find where the motor strip is, put that on his head. And Alan, you get your micro disc gets an infection. They put this thing sticking out of the kid's head, right? And he doesn't get it infected. He goes and then he plugs it into a computer. He thinks about what he wants to do. They tell him to think about picking up a fork. It goes into a computer, and then that comes out on an array onto his hand.
Great if somebody could internalize that, not have anything sticking out of someone's head.
And I think they're going to get there. So this is his study when he first came in. They just did it, proof of principle. He can move his arm thinking about it. So that's great. This is their first prototype. And this is today. This is about 3 years ago. I got this from Ali Razai. So he's thinking about this. This is not thinking about it. Him thinking, I'm going to pick that up and drop. This is a bad one. I'm trying to figure out how I can get my wife to unplug. And then lastly, my last slide, I just want to talk about, this gets even more amazing. So this is Peter Conrad up at Vanderbilt. He sent me this slide. They have a cat model and they transect the spinal cord. So you are getting zero impulses. And then they put, I don't know if you guys can see it, see the little whispers in there? Those are interparenchymal wires that go into the parenchyma of the spinal cord of the cat. They then program it, and they teach the cat, who now has transected hind limbs, right? And they can get the cat to ambulate just by sending electrical signals in. So to go back to your thought, Alan, I totally agree with you. I think this is going to be, we're going to put electrodes into spinal cords. We're going to reprogram how they do it. And it's such an evolving and rapidly advancing field. It's amazing. I think that's all I have. This is my team and the trials we're on. And I thank you guys very much.
Great job, Jim. We're excited to have you here. The one question I have about, well, I have lots of questions about Staskus, but they say it's statistically significant with 2 Asia level improvement in the less than 24-hour group. Does that mean that 1 level improvement was always also statistically significant? Because it's not in the paper.
It wasn't.
So why wasn't it in the paper? Because it wasn't statistically significant?
No, it's not statistically significant.
So one level improvement was not, 2 level was.
I'm going back to the slide.
It's not in the slide.
It's in the slide. It has 1 level. The same.
So why is that?
Why is that?
Yeah. Wouldn't you expect 1 level and 2 level both to be better? I mean, those are really small numbers of patients that the whole paper is contingent on. I don't know if you mentioned it, but also the early group was younger,
had more steroids.
Had-
They were not the same.
Yeah, they were different. I didn't go through the whole thing, but
Yeah.
you are totally right. There are definitely
Yeah.
some points.
I mean, I'm a big believer of early surgery. This is a retrospective
If you're
analysis.
Canadian and you're not nice, you move to Miami. I'm not going to say anything different, but
It's a retrospective
I can't say that. Give
analysis,
guess.
but there's there's issues. There's issues. And Dr. Tatter always wanted to do a prospective randomized study, which is really what you need to do.
By the way, I just told you that story.
I
You
missed
came
it.
in late. So we
Yes.
started to do a prospective study and they only enrolled 12 patients. And
Right.
guess who enrolled 8 of them? Me. And I said to myself, there's no statistical way in the world, because I was a math major, that I always get the guy at 2 o'clock in the morning that gets the emergent surgery. And
No,
then
I
the
did hear
orthopedic
that
surgeon
story.
told me 20 years later, it's because, oh, we just we got rid of the card if it was.
But that study was never, it was never
didn't do it.
NIH funded and it was never approved. The one that he put together 25 years ago.
Correct. And we couldn't get enough people to do it. So
Uh-huh.
we tried to do it as a pilot study to do it. And after 6 months, we had like
I got it.
6 patients involved and they all came from Jefferson.
So yeah, some Canadians come to Miami and they are nice.
Oh, are they?
But my just a comment with the stimulation of the spinal cord. You can actually you have to vary your stimulation protocol because you can get trained people to stand,
Yep.
and people who are trained to stand don't walk as well. So they have to be trained to walk in order to walk. And also there are effects on, like you mentioned, cardiovascular effects and
Well, I think-
bladder and stuff like that. So there, it seems to be very dependent upon location and also parameters of stimulation and how it's stimulated.
I totally agree with you. I think we have not even, and I love Dr. Harkman. I think she's a genius, but it's very interesting. They used the standard workman's comp spinal cord stimulator and kind of, hypothesize where to place it. We don't know where to put it yet, why to put it, what leads to do. The neuromodulation field is exploded. Now they have dorsal root ganglion, which might be better for the spinal cord stimulated population. So, I think there's just that is just so exciting to me. It goes back, there's a guy named Shapiro, who probably most people don't know this, at University of Indiana. He was the first guy, and his study was very interesting. He took spinal cord injured patients and he put stimulators on their back of their posterior columns on his neck, did a posterior cervical laminectomy and laid the leads on the neck. And what those patients did is they improved their posterior column function, which to me was fascinating, because does the stimulation go deep enough to get to the anterior horns? And so I think we don't know anything about electrical effect from that point of view. And it works for bone fusions too. So that's good too. Well, thank you guys for having me.